أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. I'm Dr. Fayyaz, Vice President, Pakistan Society of Headaches. I welcome you all and thanks for joining. I will start from the Quran recitation. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. First of all, I will give you a short intro of our speaker, Dr. Fayyaz Ahmed, who is currently working as a neurologist at the Hull York Medical School and Teaching Hospital, UK. He qualified from Doe Medical College, Karachi, Pakistan in 1986 and then moved to the UK. He received his training at the St. James University Hospital, Leeds, and Imperial College of Medicine, London, where he received clinical and research training in headache disorders at the Princess Margaret Migraine Clinic. He is involved in the field of headache for 28 years and contributed towards headache research, management, and education. He established the Hull Headache Clinic in 1996, and that is providing tertiary care management in headache disorders. I had the opportunity to be part of that headache clinic as well. Dr. Fayyaz Ahmed of Migraine Trust International Symposium and served on NICE and BASH committee in the development of headache guidelines. I would like to invite Professor Adnan Khan Saab, who is the chairperson and the president of the Pakistan Society of Headaches, to have a few words before we start the formal lecture, please. Professor Adnan Khan Saab.
Thank you very much. Assalamu alaikum to everyone. I warmly welcome Professor Fayyaz Ahmed Sheikh for his and all my neurology colleagues, both senior and junior, for taking off their time on this Sunday, which is a rest day, I'm sure, but they have taken off this time. Basically, this is arranged by the Pakistan Headache Society, which comes under the umbrella of Pakistan Society of Neurology, Pakistan Society of Neurology. About Dr. Fayyaz, I think Ayaz has given you a proper introduction of his. I think with this, we can start off with his lectures. Thank you very much.
If you let me share the screen, Ayaz.
Okay, sir.
I'm trying to share the screen, but it wouldn't let me do it.
Okay, sir. I'm just sharing.
Okay, that's good. So is everybody can see that?
Yes, sir.
Okay, well, thanks very much for asking me to do it. And as I said, Fayyaz asked me to do it, and I can't refuse Fayyaz because I know him for a long time. Fayyaz used to work in our department quite a few years ago. And I think this is a very good initiative by the Pakistan Headache Society. And I think one thing that Corona has done to all of us is good that we can now do these kind of meetings rather than personally face-to-face meeting. Although I think the face-to-face meeting is still a good thing to do the networking, but I think most of the educations are now going via the electronic media. So thanks for inviting and thanks for your introduction, Fayyaz. I start with the picture of the Dow Medical College. I think most of you would have visited. It has changed completely since I left 24 years ago. So these are my disclosures, which I have to declare. Okay, so what we're going to learn in the next 45 minutes is what are these trigeminal autonomic cephalalgias? What are the main types? How you would differentiate them between each other? A brief pathophysiology as to which part of the brain does get involved. A brief look into the differential diagnosis and investigation. And I think because the commonest TAC is cluster headache, therefore I think it is reasonable to then discuss cluster headache as a sole topic for the manifestations, treatment, because this is the most common form of the trigeminal autonomic cephalalgia. If the time is left, then we could do some interesting cases at the end. If there is no time, then we'll just take the questions. Okay, so what are trigeminal autonomic cephalalgias? Now, if you remember the headache classification, you have primary headaches and secondary headaches. So secondary headaches, you are all aware, the brain tumor, the subarachnoid hemorrhage, and all where there is a structural cause to it. When you can't find the reason for headache, then that's a primary headache disorder. The primary headache disorders are then divided into those headaches that are longer lasting without treatment. So if you don't treat the headache and it goes on beyond 4 hours, usually up to 72 hours, then that is long-lasting headaches, and migraine is the most common form of that, migraine, tension headaches. If the headaches without treatment last for less than 4 hours, then majority of them are associated with some autonomic features like runny eyes, runny nose, redness of the eyes, nasal congestion. These disorders are called trigeminal autonomic cephalalgias. Trigeminal because they are in the distribution of trigeminal, obviously autonomic because they are all associated with autonomic symptoms, and obviously they cause the most terrible headaches. So the commonest feature of these headache is that mostly the pain is strictly within the first division of the trigeminal. They are excruciating and people are restless when they experience this, compared to migraine where people want to go and lie down quietly and don't want to move. These are short lasting and they have autonomic features. Now the commonest of it is cluster headache. And I think vast majority of people who have interest in headache or are even general neurologists would come across cluster headache at least once every few months. And if you have a headache interest, then you'll probably see quite a lot of them. So I would say that 90 to 95% of what you see in TAC is cluster. Then obviously uncommon, but still need to be differentiated is paroxysmal hemicranias. And then the short-lasting neuralgiform headache. Neuralgiform means because they give you pain similar to trigeminal neuralgia. That's why they're called neuralgiform headaches. So short-lasting unilateral neuralgiform headaches. And then there is one called HEMICRANIA continua, which is now included in the TAC. For a long time, HEMICRANIA continua was not a part of the TAC. Now it's included in the TAC. So basically, on your left on the screen are the different forms of TACs, and on the right are the common features for all TACs that you would see. So let's talk about the first one, which we would also talk in very much detail later on. So cluster headache is the most common form of the TAC. Compared to migraine, if you don't treat it, it would go on its own within 4 hours or less than 4 hours. The IHS definition is between 15 minutes to 3 hours. A lot of people with migraine, when they take painkillers, the pain goes away in a couple of hours. So this is why I stress on the point, untreated, the pain goes on its own. A lot of people with TAC or cluster headache think that they take the painkiller and the pain goes away. So it's the painkiller that has worked. It's not the painkiller that has worked, because they all take it orally. So it is not the painkiller that has worked. If they wouldn't have taken the painkiller, the pain would have still gone away. And you've got obviously restlessness and autonomic features, which is the common thing. Now the second one is paroxysmal hemicrania. So the one in the black is the common features to all TAC, and the one which is a little bit different is that this is characterized by between more than 5 attacks a day for at least half of the time, and the duration is 2 to 30 minutes. So look at the overlap. Cluster 15 minutes to 3 hours, this is 2 to 30 minutes. Cluster 1 every other day to 8 a day, this is more than 5 a day, half of the time. Usually it's between 10 to 20 times a day. So that's the only difference. All others are very similar to all TAC. You then go to short-lasting unilateral neuralgiform headaches. If they are associated with any autonomic features, then you call it SUNA, short-lasting unilateral neuralgiform headaches with autonomic features. And if the autonomic feature is conjunctival injection or conjunctival tearing, then it is called SUNC. So the last of the CT is called conjunctival tearing. So these are more than 1 attack a day, at least half of the time. Now look at the duration is between 1 second to 600 seconds, i.e. 10 minutes. And there are triggers. Now it resembles trigeminal neuralgia, because trigeminal neuralgia is also very short lasting. Trigeminal neuralgia can be triggered as well by eating, chewing, swallowing. But with trigeminal neuralgia, you'll have a refractory period, so where you can't trigger it. But in SUNC and SUNA, you trigger it all the time. There is no refractory period. All other features are very similar to all the TACs. So what is hemicrania continua? So that it was not a part of TAC for a long time was because of the duration, because it's a continuous pain. Therefore, some people resisted getting it into the TAC. So it's a strictly unilateral headache. It has to be there for 3 months. It has to be moderate to severe. And it would either have the autonomic features or it would have restlessness or agitation. The only particular thing about this is that it responds dramatically or absolutely to the therapeutic dose of indomethacin. So that's the particular feature of the hemicrania continua. Excuse me, I'll just have some water. Right, so this is the slide which would give you a brief difference between them. So look at the cluster, attack frequency 1 to 8, 1 to 40 for the paroxysmal hemicrania, 1 to 200 SUNC and SUNA, and hemicrania continua, continuous pain. Duration is a bit of an overlap, continuous in case of hemicrania. All are sharp, throbbing, excruciating, apart from SUNC SUNA, which is neuralgiform. So very similar to trigeminal neuralgia. The golden rule is that if you get trigeminal neuralgia in V1, usually trigeminal neuralgia is in V2 and V3. If you get trigeminal neuralgia in V1, always think this could be SUNT or SUNA. It may not be trigeminal neuralgia. So there is a lot of overlap. The pain intensity is severe in all of them. There is circadian rhythm, which is particularly more common for cluster headache, but a bit with the paroxysmal hemicrania. Autonomic features is common to all of them. Migraine features are also present in all of them. Restlessness and agitation is more with cluster and paroxysmal hemicrania and hemicrania continua, but they do occur on SUNT and SUNA as well. Similarly, the restlessness and agitation is also common to all forms of TACs. Now, cluster headache does get aura in about 14%. So presence of aura should not really exclude cluster headache, but its other TAC is obviously rare. And alcohol is the most common trigger for cluster and others, but SUNT and SUNA is only the cutaneous trigger. So you touch, you get the pain, you touch, you get the pain. That's very unique for the neurology forms. Most of the cluster are episodic, and as you go towards the shorter duration, most of them become chronic, like 100% of hemicrania continua are chronic. And here you see the most common is cluster. SUNT SUNA is more common than paroxysmal hemicrania, and nobody knows how common is hemicrania continua, because the problem with hemicrania continua is that it has got features of migraine as well as it has features of TAC. So a lot of time it can get mixed and missed as well. Okay, so a little understanding of the TAC is that they are all related to hypothalamus. So hypothalamus is involved in all forms of autonomic behavior, stress, emotional, and therefore you see that the circadian and circannual periodicity of cluster, the change in the hormone levels, excuse me, related to stress and sleep. So a lot of these factors indicate that hypothalamus dysfunction is basically unique to the pathophysiology of all underlying trigeminal autonomic cephalalgias. Excuse me. It's not as hot as in Pakistan, but it's quite hot today here in UK. Right, so this is the PET studies, which was mainly done by Arne May, who's the editor-in-chief of Cephalalgia, and Manjit Mathuru, who's one of the world authority in cluster headache. And it shows that hypothalamus and the surrounding areas do get involved in the pathophysiology of a trigeminal autonomic cephalalgia. So therefore, we know that hypothalamus is involved. However, the studies on the deep brain stimulation, which I will discuss a little later, shows that it is not the actual hypothalamus, is the posterior part of the hypothalamus between hypothalamus and red nucleus, that area of the midbrain tegmentum. That is the one which is actually get involved in the pathophysiology, because all the DBS studies that shows a lot of improvement are actually done in the midbrain tegmentum area, or posterior hypothalamus. Normally, there is a form of a trigeminal autonomic loop, and we think that hypothalamus is involved in the excitation and inhibition of that trigeminal autonomic loop. If that trigeminal autonomic loop does get disturbed, therefore more autonomic features occur because the inhibition by the hypothalamus is gone. So one of the pathophysiology is hypothalamus and the connection of hypothalamus with the rest of the nervous system. And also CGRP has been shown to be increased in cluster headache, and triptans, when you give for cluster, can reduce the release of the CGRP. So that's also a potential pathophysiological mechanism. Now, we don't really know what pituitary has got to do with the TAC, because every now and then you see cases published where pituitary is involved in TACs. Now, it is very difficult. The question basically is raised, should you be doing MRIs with pituitary cuts in everybody with TAC? So there is not a huge amount of data available out there. The Manjit Matthews and group had 37 cases of trigeminal autonomic cephalalgias that they picked up over many, many years from Queen Square. They found that about 17 of them had pituitary tumors. Majority were microadenomas and some were macroadenomas. Now, does that have anything to do with whether this was an incidental finding? We don't know. This is not a huge series of cases. There is another study by Levi where they picked up 84 pituitary tumors and studied them and found out about 4% of them present with cluster headache and another 4 or 5% presented with sun-torsuna. So a total number, about 9% of those pituitary tumors presented with the trigeminal autonomic cephalalgia. So should we do a scan or pituitary cut on everybody? I think at the moment, Manjit Matthews group in Queen Square is looking at how many MRIs are positive. And I think they find that it's very rare. If you scan everybody, you wouldn't pick more than one or hardly two or for many, many hundreds of pituitary abnormalities. Remember that if you scan everyone, 1 in 10 people would have pituitary microadenoma anyway, and about 0.2% or 1 in 500 would have pituitary macroadenoma. So is there a link or not link? It's very difficult to ascertain. What I practice, I do not do scans with the first episode of cluster, if it is very typical. Once they behave atypically, and there are atypical features, or if it is refractory to treatment, I usually scan them. Non-cluster TACs like sun, sooner, hemicrania, continua, paroxysmal, I scan all of them. One, because they are very rare, and secondly, very few would present with very typical clinical features. So I think it is probably a good idea to scan all TACs, not the cluster, but cluster with atypical features that you would scan. So this is what I would do, and yeah, I was listening to Queen Square practice, and they do exactly the same. They find that there is a neurovascular conflict, so they are not looking just for pituitary abnormalities, but they are also looking for some vascular problems like aberrant vessel touching the trigeminal nerve. Okay, so what is the main differential diagnosis of TAC? So trigeminal neuralgia is the main one, and as I already said, you have trigeminal neuralgia in the maxillary and mandibular division of trigeminal nerve. If it's very similar to trigeminal neuralgia, but it's in here, always think about sun-sooner, TAC. Because in trigeminal neuralgia, autonomic features are unusual. They are same triggers, but not just the sensory triggers, eating, chewing, washing your face, shaving, swallowing, they can all precipitate it. And there is usually a refractory period, which is not there in TACs. So that's one most common thing that can be missed. The second one is idiopathic stabbing headaches, also known as primary stabbing headache or ice pick headaches. Now, vast majority of ice pick headaches would be like short, sharp pain that come in any part of the head, mainly B1 distribution, and it comes and goes away very quickly. People think that something has burst inside their head, exploded something. These are fairly benign, but some of them can last a bit longer. So do not exclude them if they go on for longer than a few seconds. So these have no autonomic features, and you can't trigger them. They just come on their own. Excuse me. Okay, so let's come to cluster headache, which is obviously the most common form of the trigeminal autonomic cephalalgia. And if you can diagnose cluster headache confidently, then I think you are a good headache specialist. because one thing that differentiates between a neurologist and a headache specialist is that neurologists, one, do not see many cluster headache, and they do miss a few cluster headaches. Because migraine is common, so a lot of people would think these are migraine because common things are always common. So if you can diagnose cluster headache with confidence, then it does mean that you have an interest and you have an expertise in headache disorders. Okay, so how do you make a diagnosis of cluster headache? I'll give you 2 or 3 very quick points. People with migraine would go and lie down in a dark and a quiet room. People with cluster headache would not go to a dark and a quiet room and rest. They would not sit still. They would be extremely restless, and they would have, continue to, toss, rock, move around, do anything to get rid of the pain. People with migraine would describe the pain as severe. A cluster headache would describe the pain as excruciating. So some of the words that I have heard from patient is, I want to shoot myself. I want to put my head under the car wheel. And I want to jump out of the window. I want to kill myself. So these migraineurs would never say that. Migraine is, if you don't treat it, it would go on for longer, but cluster headache would terminate on its own, okay? And obviously the frequency is there, but autonomic features can be present in about 1/3 of patients with migraine. 1/3 of migraine patients can have autonomic features. The vast majority or almost all of cluster headache would have autonomic features. So that doesn't really that much differentiate. There is a circadian and circa-annual periodicity. People often wake up at the same time during the night with a cluster headache, or it occurs at the same time every day. Some people call it alarm clock headache because it wakes them up at the same time every day. So that's another thing. So these 2 or 3 things are mainly the differentiating factors. When I started to work in headache 20 years ago, we used to read that it is 9 times more common in men. It's not true. I think females are affected, but a lot of female, because migraine is very common, are labeled as migraine, and therefore there is a huge misdiagnosis can occur in women. We just published a paper in the British Journal of General Practice that a lot of people with cluster headaches are labeled as migraine, and they can go to ENT, they go to neurosurgeons, orthopedic surgeons, dentists, and others because their diagnosis is missed. Still, I think an average 3 or 4 doctors would see a patient before making a diagnosis of cluster. And an average patient 2.5 to 3 years before he receives the right diagnosis. So I think one thing that you want to take away from this talk is how confident you feel making a diagnosis of cluster headache. And if you do feel confident, you've learned something. Okay, so let's talk about the treatments of cluster headache. Obviously, if you diagnose migraine, you give migraine treatments. A lot of migraine treatments don't work for cluster. So the cluster headache treatments are 3: abortive treatment, which is used for a cluster attack. Then there is bridging treatment, and then there is prophylactic treatment. So let's talk about the abortive treatment of a cluster attack. So oxygen is probably the best acute treatment. The evidence came from the randomized controlled trial by Anna Cohen in 2007, and it showed 80%, nearly 80% responded to oxygen compared to 20% placebo. The main factor is you have to use 100%. You have to use high pressure, 12 liters a minute, and you have to do it with a special mask so that the holes are all covered. Because if there is a leakage and if they are not getting high pressure and they're not getting pure oxygen, it may not work. The second is the subcut injection of imigran, 6 milligram, but I don't know whether it's arrived in Pakistan, but I think it is sooner arriving in the UK. 2 milligrams and 3 milligrams injections are coming, because a lot of people can take half of the injection and use 2 cluster attacks with 1 6 milligrams. So they have now looked into it, and I think the trial evidence has shows that 2 milligrams and 3 milligrams is as good as 6 milligrams. And therefore, because it's expensive in the UK, they give you 2 injections per 24 hours. So you can treat 4 attacks if you divide them into half and half, so that when the 2 milligrams and 3 milligrams, you'll be able to use more of it. Injections, if you can't use or if you don't want to use, then the nasal spray. So there are trials from the sumatriptan nasal spray and the zolmitriptan nasal spray. And they both shows good evidence. Usually the nasal spray work in up to 30 minutes, but the injection usually works within 15 minutes. This is the summary of the different ones. So this is oxygen. This is sumatriptan injection, nearly 74% at 15 minutes. Nasal spray in 30 minutes, still very good. So the message is, do not give any tablets to people with cluster headache. Don't give any tablets. There is no point in giving paracetamol, cocodamol, codeine, and nothing would work. Always remember that the time taken for the tablet to get into the brain and have the analgesic effect is about 2 hours. Most of the migraine trials look at the pain response or pain relief at 2 hours. Vast majority of cluster headache would have gone by 2 hours, some up to 3 hours. So therefore, tablets are of no use, and therefore you either use the oxygen or the nasal spray or the injection. What if these do not work? Well, there is some evidence of intranasal lidocaine. I have not used it, but there is one paper, and there is not very convincing data of the intranasal lidocaine. I have no experience. There is one trial of subcutaneous octreotide. So octreotide is a synthetic somatostatin, which people use for acromegaly. It's very expensive. I have one patient who is addicted to octreotide and uses about 20 to 25 injections per 24 hours. She is addicted to octreotide. She would not leave it. Nothing has worked for her, but she would continue to use octreotide. It does work. There's only one trial, which is Peter Goadsby and Manjit Mathur did in 2004. It's promising, but it's very, very expensive. What others? Vagal nerve stimulation. Now, gamma core or vagal nerve stimulation is being tried in 2 trials, Act 1 and Act 2. And in both of them, it showed episodic cluster headache. The attacks in episodic cluster headache do respond, but there is no role in chronic cluster headache. However, I think there are more studies and are still being carried out for that. What's other thing there for abortive treatment? Now, sphenopalatine ganglion stimulation. There is a microchip that goes under the gums with a remote control with which you can stimulate or stop stimulation. It first came out with the double-blind study by John Schunan in Belgium, and they showed it was very effective. You can see on the right that full stimulation, about 65% people responded quite nicely compared to very little with substimulation or non-stimulation. The results were replicated recently by Peter Goadsby's group, presented in the American Headache Society, very similar. 93 patients, so many attacks treated, 15-minute response, very similar, although the sham response here was a little higher, but there was quite a good response. Overall, response was 71%. Acute attack responded quite well. Frequency of clusters also responded, and about a quarter of people have response to both the severity as well as the frequency of cluster attacks. This was manufactured by the company called ATI, and ATI went bankrupt about a year ago. This is not out there anymore. But I'm sure whoever would buy the bankrupt ATI would probably bring it in one of the other forms sooner in the market. So watch out for it, basically, that it might come back again. So what are the bridging treatments? So the bridging treatment is neither an acute treatment, neither is the prophylaxis. If you put prophylactic treatment, it takes a little while to work. So what do you do in between? Because the pain or attacks are so severe and disabling, you have to do something. So oral steroid. My usual practice is that I give 60 milligram of prednisolone for 5 days. Then I reduce it by 5 milligram per day until they stop. So that would be 17 days of steroid. The problem is as soon as you come down to 20 or less than 20 milligram per day, the attacks start to come back again. The evidence first came from a study in 1975, but just about 2 weeks ago, Mark Oberman presented his data in the American Headache Society meeting this year, and a very good data comes out. He used 100 milligram of prednisolone for 5 days, reducing by 20 milligrams every third day, and there was about a 50% reduction versus 15% in placebo. So there is good data out there for oral steroids. The problem is that it's a short-term treatment, and you have to put prophylactic treatment at the start as well. What if you don't want to use oral steroid? You can do the nerve blocks. So there are 2 types of nerve blocks that you can do. The most popular at the moment is greater occipital nerve block. So basically, I give 80 milligrams of depomedrol with 2 ml of 2% lignocaine. You can use unilateral or ipsilateral greater occipital nerve block. There is no evidence that a bilateral greater occipital nerve block are superior to the one done on the side of the pain. But over the years, my experience has been that if I do ipsilateral, some people would start to develop pain on the other side. So I have had good experience, and it's anecdotal, on doing bilateral greater occipital nerve block. So I always do bilateral greater occipital nerve block. So 40 milligrams on each side I give. And a lot of people get very good evidence. I think the data by the Elizabeth Leroux published in Lancet, about 50% or more than 50% got better versus 0% in placebo. So that was a very convincing effect. The Queen Square group, led by Manjit Mathuru, they do multiple cranial nerve blocks, and their recent data has been in cephalalgia last year. They do supraorbital, supratrochlear, auriculotemporal, lesser temporal, and greater occipital. They infiltrate multiple cranial nerves, and their data has been quite good. These are the people who were refractory to treatment, refractory to greater occipital nerve block, chronic cluster headache. And you can see that 69% responded within 2 weeks, and about 50% of them are pain-free. So those refractory people, half of them being pain-free, I think these are very good results as such. So worth pursuing that. What about prophylactic treatment for cluster headache? So the good evidence, the best evidence is for verapamil. 120 milligram 3 times a day to start with. And the paper by Massimo Leon in 2000, 80% people got better within 2 weeks compared to 0% in placebo. You usually start with 80 milligram 3 times a day. I usually leave it to 80 milligram 3 times a day. And if they are no better in 2 weeks, then I increase it by 80 to 120 milligrams every week until they are better, or they get up to a dose of 960 milligram per day. You have to do an ECG every time you alter the dose. It is better to look for the degree of bradycardia and the heart block. As you know, that about a third of people would develop bradycardia, although vast majority I have seen is about 45, 50. They don't go any lower than that. There was a paper by Anna Cohen that about 1 in 5 people could develop a little bit of a rhythm disturbance, of which about 12% develop first degree heart block and 7% second degree heart block. 10% people you'll have to stop verapamil because of that. That's quite a big number of people to stop verapamil if you consider you're treating with something like verapamil. The second drug with a good RCT evidence is lithium, a crossover study by Buson in 1990. And most of the people that respond to lithium respond to a higher dose. The problem with lithium is that its therapeutic window is very narrow. So you start with 200 milligram, you check the blood levels a week later. It has to be between 0.8 to 1.2. If it's in the therapeutic range and it hasn't worked, you go to 400, and in this way you keep increasing by 200 to 400 weekly or fortnightly until you get to a dose of about 1600. And the problem with lithium is that a lot of people are not able to tolerate it properly. People develop tremor, thyroid problems, and other things. My experience is that some people that have responded to lithium were the one with the chronic cluster headache. I have very rarely used it in episodic cluster headache. A lot of people would get better with a nerve block and verapamil as such. The other RCT evidence exists for melatonin. By, again, Massimiliano in 1996, 10 milligram melatonin versus placebo. Very good response to 50% versus none to placebo. So melatonin is probably good for people getting nocturnal clusters as well. The Gamma Core trial for prevention of cluster headache was called PREVA study done by Charlie Gall. It was an open label study. They compared Gamma Core versus standard of care. And they found about less than 25% or less response in about 76%, 50% respond by 50%, and 20% respond about 75%, and in 2% it was completely gone. The benefit was in the episodic cluster attacks, not in the chronic cluster headache. So it's open label, and I think you'll have to make your own judgment. But I think Gamma Core is worth pursuing if your first line treatments are failing. What about this new CGRP monoclonal antibodies? The galcanezumab has shown some improvement in episodic cluster headache, but not in chronic cluster headache. This paper by Peter Goadsby, 106 patients completed 90, half of them was on placebo, half on galcanezumab, and very high placebo response, 53% placebo response, but a very good therapeutic gain of about 18%, right, which is most of the drugs that we read have got a therapeutic gain of about 20-25%. So that's pretty reasonable. Well, FDA in America has approved it for cluster headache, but European Medical Agency has rejected it. They want more trial evidence because it's only a single study. It's up to Lilly whether they would want to do more studies or not, but currently it's not used in Europe, but it's used in America for episodic cluster headache. What about invasive treatments? So there are two invasive treatments used for cluster extremely refractory cases. One is the occipital nerve stimulation. So you have the electrodes, put it in here, and the machine is here, the stimulator, and usually done with the remote control. There is some experience by the Queen Square people, Sarah Miller group, and they have shown that the longer you go, the better it gets. So it doesn't work straight away. So this is 3 months, 6 months. So the real benefit really start to come after about 18 to 24 months. It's invasive. I've had a few patients got it done. Some have responded really well. Some have responded a little bit, but it's invasive, and obviously it only comes if everything else fails. The deep brain stimulation, obviously there have been few patients done in Italy by Massimo Leon, and the Queen Square people have done. It's got a good response. About 64% patients do show good response, but because it's fairly invasive, it's really done for very severe refractory and resistant population as such. But that's something that there's some data out there. So what about health? You got verapamil, lithium, melatonin with RCT evidence and others. When you're clutching the straw and nothing is working, some of these treatments you could try. Gabapentin, they are all been in the open trial or open label evidence for gabapentin, for valproate, for topiramate. There is one series of cases for levetiracetam. Obviously, when nothing is working, you could try baclofen, Botox, IV, DHE, but there is no evidence, but there have been anecdotal reports about them. So it may be worth pursuing them. I'm going to show you a video. I hope it works. I hope it does work. Try one more time, and if it doesn't work, then we'll skip. Anyway, if it doesn't work, obviously, I mean, I would have the slides. This is in recording, so you can click the link. This is a CNN video of patients with cluster headache and describe what a cluster patient looked like during an attack. So it's worth a watch. I thought it would work, but I do apologize that it hasn't worked. Right, I think I'll take the questions, and if there is some time left, we could do the cases. Thank you very much.
Thank you very much, Dr. Fayyaz. I got a question in our chat box from Dr. Sara, and I will read out the question. During the talk, you mentioned that the cluster headache is a typical time clock or alarm clock. So our question is that the typical alarm clock is it hypnic headache or cluster headache? How do you differentiate?
Yeah, well, normally the alarm clock headaches is hypnic headaches, but because sometimes you wake up with this headache at the same time every night, some people also call this one as an alarm clock headache.